Hey everybody, I wanted to share this short video with you on schizophrenia because I can't be in class and just wanted to add some extra things, drive home a few points. So let's dive right into it. I'll try and keep this really brief, about 25 minutes. With schizophrenia, what our learning objectives today are to list symptoms in clusters, which are positive, negative, and cognitive symptoms. And then we're going to talk about the psychiatric terms that are related to schizophrenia symptomatology. And then we're going to talk about behaviors, complaints, symptoms, but we're going to use the correct terminology. We will talk about some drugs that could introduce psychosis, and we'll describe comorbidities affecting folks with schizophrenia. So, what is schizophrenia? Well, it's a chronic brain disorder. There's no cure for schizophrenia. A lot of times I hear stories about people that had schizophrenia and then it went away. They likely did not have schizophrenia. It's relatively rare, just about 1% of the population. And I would argue that it's to me, it's one of the most fascinating but also scary psychiatric disorders. The symptoms can include things like delusions, hallucinations, disorganized speech. You're going to hear me talk a lot about speech today, troubles with cognition, and lack of motivation. So we should use the term person-centered terminology. We should say a person with schizophrenia, not a schizophrenic. I have a video here at the bottom that you might want to look up. It's a TED Talk from Ellen Sachs, and it's really interesting. It's a little older, but it's about her perspective having schizophrenia and what's that's like. So our origin, the term that was first used in the 1890s, dementia praecox by Arnold Pick. Then a little later in the early 1900s, Emil Kraepelin. Remember, we talked about him in manic depressive psychosis. Uh, he differentiated between that and dementia praecox. I'll come back to that a little bit later here, what that means. And then Eugene Bloiler. He published Dementia Praecox, or the group of schizophrenias. That's an important note there because there are different presentations of schizophrenia. People with schizophrenia will look very different. We talked about that with depression too. So praecox means very early. Dementia is our loss of cognitive functions, which to me, it's kind of like we have come full circle. I'll talk about later about how cognitive functioning is something we think about now. So long ago, with Boiler, he would talk about the four A's of schizophrenia: association. So those are our cognitive associations, and we might use terms like loose association. You'll learn about that in a little bit. Affectivity, that's affect, your emotional response to things. Ambivalence, like lack of motivation. And autism here means turning into the self. So think of it a little differently from autism spectrum disorder. So on your own, I want you to try and figure out what schizophrenia means. So Google schizophrenia, see if you can figure it out. So again, here, what we're talking about is psychosis, in contrast to neurosis. You've heard me say that like a million times. So what we're talking about is losing touch with reality. So we would call that a psychotic episode when somebody's thoughts and perceptions are seriously disturbed. They might have difficulty understanding what's real and what's not real. So delusions, those are those fixed false belief systems that people hold on to rigidly despite evidence to the contrary. No matter what you say, they hold on to them. And there's lots of different types of delusions. So some common ones are persecutory or paranoid delusions. People who think folks are following them, spying on them, out to get them. Erotomanic, those are like romantic things, like I'm destined to be with this person, or this person is secretly in love with me. Like I'm meant to marry Jodie Foster. You might know the historical reference there. Grandiose, people might think they're like the reincarnation of somebody famous, like Napoleon. Uh, Jealous. So you see that, like that makes good content for television shows like Maury Povich or um, uh, Jerry Springer. Like somebody's always jealous. They think their partner's always cheating on them. And then somatic, that's really interesting. Folks might think that they have like an implant, something in their brain. It's common to see people pull out teeth. They'll think tracking devices are in their teeth. Sometimes it gets really wild and they'll think that something's like implanted into their genitalia. Um, so I do always think about with medications that sometimes we use antipsychotic drugs that are suspended in a like non-dissolvable matrix. So somebody will pass that through their GI system and they'll see it in the toilet. Uh, so, you know, you could take things in real life and then sort of spin them into a delusion. And then again, hallucinations. So the definition of a hallucination is um, uh, a sensory experience in the absence of an actual stimuli. So you can have those in all your senses. Here, what we're most concerned about is auditory, and then to a lesser degree, visual hallucinations. Those other ones could happen, but oftentimes, like tactile, gustatory, olfactory, those are associated with other disorders. So hearing voices is the major thing. So we differentiate between positive and negative symptoms. Positive are things that are added on, okay? Things that you take a regular person and you add on these extra things, like hallucinations, delusions, disorganized speech, loose associations. That's like their thoughts are not quite making sense. They're loosely connected, but you would have trouble following where they're going. They might be off on a tangent. You know what that's like because of your professors. Their speech actually might be so disturbed that it's incoherent. How do we know that somebody has disorganized thoughts? It's hard to tell what somebody's thinking. You look at their speech. And their behavior might be disorganized. And they might be wearing winter coats in the summer. You might see somebody collecting what appears to you to be like trash, but for them, it's something different. And then catatonic behavior, which we've talked about. Catatonic states that's a little different from cataplexy. Catatonia would be somebody that is stuck in a position. There's different types of catatonia, and it might be like purposeless, repetitive movements. And then here's negative symptoms. So, negative affect. Their facial expressions are really flat. That could be a side effect of medication, though, too, which makes that a little confusing. Alogia or poverty of speech, anhedonia, they're not having much fun. Avolition, lack of motivation. Psychomotor retardation. So here, retardation just means slowing of cognitive and motor functions, lack of socialization, and loss of emotional connectedness with others. So negative, these things go away. And then cognitive symptoms. Again, these have been recognized more recently. When I was in graduate school, we didn't learn about cognitive symptoms at all, but they are very prominent. And I mean, I see people with schizophrenia not too often, but a lot of times I give them an IQ test, and these folks have been to college, but they do extremely poorly on an IQ test. It's not that their IQ has dropped. I mean, I guess it has on this on a test, but the question is why? And it's likely because of problems with attention, concentration, things like processing speed. They're really slow. Working memory is the ability to temporarily store and manipulate information in your head, like remembering a list of groceries or like numbers for a phone number, something like that. Long-term memory. Executive functioning is the ability to think and plan ahead in the future, sort of your frontal lobe functions. They have difficulty with skill acquisition. and that leads to poor social and community function. So we're going to look at this video here, and you're going to see this young man who has disorganized speech. And here you're going to hear his speech is going to, he's going to sort of make sense, but here you're going to see those loose associations. So you'll be able to understand what he's saying, but it's hard to understand.
So, and I've seen before, if the Halo, see, like, the Halo, like, when I was 19, when I was preaching, I had my trial sermon, I used to see the light on my shadow on the ground in the daytime. And now, ever since then, it's like the light coming and pulling down over my body, around my shadow, and over my body, around my shadow, and I see the light, which is your Halo, me, your aura.
So like there, you can sort of understand what he's getting at, but not really. Sometimes you get symptoms like word salad, which is a mix of random words. You could have echolalia. That's actually common in autism too, where somebody like parrots what you say, or clanging, which is really interesting to see, where you hear like rhyming rhythmic speech, or people might talk in puns, similar sounding words, or alliteration. So in the DSM-4, as we move into the DSM-5, note the change from Roman numerals to Arabic numerals. They dropped out the schizophrenia subtypes. I sort of wish they would have kept them in, but they didn't do the greatest job of differentiating the different presentations with schizophrenia. These are main categories, though. You'd see a paranoid type. Often there, delusions are the most common symptom. Paranoia, the disorganized type, that's characterized by grossly disorganized behavior or flat or inappropriate affect. Their affect, you might say like, oh, your cat just got run over by a car, and they would start laughing hysterically. And then the catatonic type, and um, there's different types there. Again, which might be excessive motor activity, and then an undifferentiated type. I would argue that if you went into a psychiatric facility and you had a group of 10 people with schizophrenia, you'd have 10 distinct presentations, that everybody looks a little different. So here's the actual DSM-5 diagnostic criteria. You need two or more of the following for at least a month. Okay. So you got to have at least a month of delusions, hallucinations, disorganized speech. And then that one of those must be present. And then these as well, grossly disorganized or catatonic behavior, are negative symptoms. So at least a month, remember that. But it's going to persist for at least 6 months. All right. And for a significant amount of time since the disturbance began, the level of functioning in one or more major areas, work, love, or play, is clearly below the level that they had prior to the onset. And then in children or adolescents, a failure to reach the expected level, again, work, love, or play, but here school. It's so rare in children. I mean, I think I've seen two in my whole career, and those families had like extreme family histories of childhood onset of schizophrenia. I wish we could have got like DNA from them because I think something probably different was going on. So symptoms have been there for at least a month, but they continue for at least 6 months. Okay. So at least a month where you meet the first criteria, and then there might be residual symptoms. So you can have kind of waxing and waning, but what this means is that the symptoms in some form are always there, even if it's just lesser. So it's not like it totally goes away. And then we want to do rule outs, things like schizoaffective disorder, which we'll talk about later, depressive or bipolar disorder. Those would be the big ones. So remember, you can have major depression with psychotic features. And then we want to make sure that these symptoms are not attributable to any other reason, substance, drug, medication, or medical condition. Just this week, I had a patient, a young woman that has Guillain-Barré encephalitis, which is pretty rare, really rare. And when she has flare-ups of Guillain-Barré, she has psychosis. She got admitted to a state psychiatric facility, got diagnosed with schizophrenia. I would argue inappropriately. She has her symptoms of psychosis are due to a medical condition, not schizophrenia. And then if somebody has autism, this note is in there. And I have had a handful of people that have autism and then they have schizophrenia. So the delusions or hallucinations, um, as well as other symptoms, are present for a month or more. And what it's like clinically is you have somebody with autism, they're developing, they have symptoms of autism, that's very clear. And then, like 18 years old, things radically change, and where you have those prominent symptoms of hallucinations, delusions. And then you specify, you don't have to specify, but you would say if catatonia is present, and then the severity. So you can see the clinician related dimensions of psychosis symptoms as a measure of severity. That's in Canvas. I'll post that. Um, so again, I'm just going to play this in the background. Actually, I don't want any sound here, but just so you can see this, catatonia can look really different too. It might be immobility, mutism. So that's not uncommon in a psychiatric facility for somebody to sit there, mute, non-responsive. They don't move. They might be staring. They might be excessively rigid. That excited catatonia is less common, but it's pretty interesting to see. And that's where people engage in that prolonged psychomotor agitation or repetitive movements over and over and over again. And just so you know, they call it a benzodiazepine challenge. Catatonia may respond to pretty high doses of benzodiazepines. Sometimes you can pull somebody out of that state. So even though this video is old, it's good at showing what that looks like. Okay, so I want you to think about what medications or drugs could cause symptoms that look like schizophrenia. There's a clue on the screen. But think of all the other things. You should be able to make a list. And then medical or psychological conditions. What could look like schizophrenia? I'm not going to tell you. There's a bunch of them. Look it up. Try and figure that out. So thinking about those things, I think that was one of the most shocking things about some of my clinical training that I did here at South Florida State Hospital. It's a beautiful facility. You have a swimming pool. That's not a joke. It's real. In that facility, we would see people come in and out, and it was kind of, I hate to use the term, but revolving door. And people would be stabilized, discharged from the hospital. They'd go use cocaine, crack cocaine for like 5 days straight. They'd be psychotic. They'd get arrested. They would come back to the hospital. They would get stabilized. That person may or may not have schizophrenia, and it requires a clinician doing a careful differential diagnosis to figure that out. On a personal story, I had a friend, um, his grandmother had schizophrenia. She was actually friends with my grandmother in childhood, but as she got older, her symptoms of schizophrenia became more pronounced, and she was in a psychiatric facility. Um, the grandson, one day we were out tobogganing at this exact toboggan track in Michigan. And this fella was in the rear seat on the toboggan, and he went tumbling out the back, kind of at the end of the track, but he hit his head pretty hard and he was like knocked out on the track. And the next toboggan came sailing down and hit him right in the head again. So probably two concussions back to back. That's not a good thing. So when somebody has a concussion, you want to pull them out of play. He was out of it for hours. I mean, it was incredible. Um, Later in life, I sort of reconnected with this guy. He came to Michigan State where I was going to school. He went to a smaller school to play football and then came to Michigan State. Um, Man, right away, like you could tell something was wrong with him. He was dating a girl that I knew from high school, um, and he went to a different high school, but dating somebody that I knew from my high school. And she would tell us all these wild stories that he would show up at her house in the middle of the night, screaming, thinking she was cheating. She was cheating on him. Think about that jealousy, those delusions. It was a mess. He lived with a group of people that I knew. One day, he had shoved a bunch of towels in the heat vents, like shoved them in there. What I was told is that he thought people were listening to him through the vents, that they were recording him. So think about that persecutory paranoid delusion. And they called his parents like, "Hey, something's wrong," and they came and got him, and he never came back. Never saw him again. So I always think about what caused that. And at the end of the day, I don't know. So the idea is that there's lots of genes. So multifactorial, lots of genes, and then several environmental factors that could contribute. Or think epigenetics, right? And so there is some evidence that like you can see physiological differences. So here's imaging showing twin studies, and that you see enlargement of the ventricles, but we can't use that to diagnose schizophrenia. So I don't know what that means. And things like chronic stress could do that too. So um, I think at the end of the day, we'll talk a little bit about uh, like with twins. Think you have identical twins, same genes. If one has schizophrenia, there's only a 50-50 shot that the other one will. That's pretty interesting. So again, we don't really know. With medication, we like to think about the dopamine hypothesis. So specifically the dopamine 2A receptor. That's where a lot of antipsychotics have their mechanism of action. And drugs that we can use the term psychotomimetic drugs. So things like amphetamines, they'll have action at that same receptor site. And I want you to think, is this related to positive or negative symptoms? And again, amphetamines, you add on somebody's acting psychotic. So the answer would be positive here. Here's just a slide kind of laying out what that genetic risk looks like. If you have a first degree relative, you do have a greatly increased risk of having schizophrenia. But even then, it's not that high. So, like a 10% chance. So, a 35% risk if both parents have schizophrenia. Here's that 50% number with monozygotic twins, 25% with dizygotic twins. It's like the most hereditary psychiatric disorder, actually ADHD. And those environmental factors, we don't know. So here's a photo from the Dutch hunger winter in World War II. The Dutch keep good records with medical and psychiatric stuff. All sorts of things happened during that time. It was an awful time to live. Famine, chronic stress, things like that. Increased risk for schizophrenia and other psychiatric disorders. But we don't know. Perinatal insults, slightly higher risk if born in the winter, head injury, like that friend of mine, hypoxia, fetal distress, infections, famine, paternal age. At the end of the day, we don't know. So schizophrenia occurs worldwide in all cultures. It's about 1% of the population internationally. So again, that's quite rare. The age of onset is typically later in life. Having onset in a geriatric population, very rare, but it happens all the time in nursing homes. I want you to think about why that might be. It's wrong. But the phase before the diagnosis, you might see some symptoms, and we call that prodromal phase. Men are far more likely to be diagnosed with schizophrenia. Women tend to be diagnosed later in life. So the age of onset for men, usually 18 to 25, just like that friend of mine. And for women later in life, 25 to 35. There's also some indication that prognosis is worse in men. But there's lots of things that can impact prognosis, like if you're higher functioning beforehand, you have family support, things like that. The other psychotic disorders that I want to talk about are schizophreniform and schizoaffective disorder. But there are other things. So schizophreniform is that first period. So this is the first month. So it's kind of like it is forming. And then symptoms must last more than a month, but less than 6 months, because if they last 6 months and one day, that's a diagnosis of schizophrenia. And then there's some information here. It says no manic depressive or mixed manic depressive episodes, because that's our next diagnosis, schizoaffective disorders. So affective is a nod to mood, and mood symptoms here with psychosis are prominent. So this is, it's kind of a tricky one. And I'm sure that Dr. Wilkening will talk to you about schizoaffective disorder and what that looks like. I see folks that, in my impression, clearly have schizoaffective disorder, but it's rare. So, like, of the people with schizophrenia, a small percentage, like maybe 5 or 10%, I'll change the diagnosis to schizoaffective disorder. But it goes the other way too. So I'll see people that are diagnosed with schizoaffective disorder, and I'll go, no, 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 they have a major depressive disorder with psychotic features. So the thing here to remember with schizoaffective is psychosis during which a significant mood episode is manifested. So you either have a major depressive episode or bipolar, which would be a manic episode, or a hypomanic episode. But the important thing to remember is that those symptoms of psychosis are always there. It's not like they have psychosis during the peak of mania or the valley of depression. And here, this is a stall illustration. I just want you to know that those symptoms of psychosis here, positive symptoms, are always present. It doesn't matter if it's just uh, it is it. I'm sorry, they are always present, not just with the peak of mania or here the pit of depression. So I hope that makes sense. So if you have any questions about psychotic disorders, feel free to reach out, email, ask me in class, whatever you have to do. It's really interesting. Usually students have a lot of questions. So I'm sorry I couldn't be there with you in class. I hope this gets you up to speed.